I'm honored to introduce Dr. Gregory J. Schears, a pediatric intensivist and anesthesiologist at a Mayo Clinic in Rochester, Minnesota. With his expertise in reducing patient complications and advancing vascular access, Dr. Schears is a leader in both pediatric and adult critical care. He heads the ECMO service, serves as a consultant in the Department of Anesthesiology, and is involved with the nurse-led PIC team. As a professor of anesthesiology, he has contributed extensively to the field through the research, product development, and numerous presentations worldwide. Dr. Schears has also served on the editorial board of Java and AVA board of directors. And next, Dr. Schears will be presenting on ECMO team and organization. Moving on to you, sir.
Good morning, everyone. I'd like to thank you for this opportunity to get to present to you today. My name is Greg Schears. I'm a pediatric intensivist and anesthesiologist by training, though I take care of both adult and pediatric patients at the Mayo Clinic in Rochester, Minnesota. I would also like to thank my colleague Troy Seelhammer, who has shared some of his slides that he's created with me for me to do this presentation. So I've had the good fortune of being able to start several ECMO programs, both in the United States and around the world. And I would like to share some information that I've developed over that time. Disclosure-wise, I'm a co-founder for ECLS Virtual Advisors, or EVA, and it's a company that helps hospitals that are developing ECMO programs to try to reduce patient complications and provide decision support, all in the name of trying to help fledgling programs or even advanced programs to improve their practice and have it a bit more uniform. I'm not going to speak about anything off-label other than the fact that much of ECMO is largely off-label. As I begin, I would like to share this bit of advice, which is if you're in the process of creating a new program, I highly recommend getting this book. Now, I'm not one to read a lot of business literature, but this is an excellent book, and it talks about it provides a 7-step researched and proven method of creating meaningful change in your institution. And starting an ECMO program certainly is a very challenging change process. You can use this approach in many different ways within your hospital in order to create change that lasts and becomes ultimately part of your culture. So I highly recommend you getting it. It's not a difficult read, and it is based on science and successful changes that have occurred in the business world. So let me provide a framework for ECMO program development. You need a number of things. This is a big commitment for a hospital healthcare system. You need, of course, institutional buy-in. You need to have physician champions. You need to have the multidisciplinary team that is going to be interacting with it, and ongoing training and quality improvement. And last but not least, you need to have expertise. That's a lot of asks that you need to have come together. Fortunately, ECMO is a very exciting practice, and it does really a lot of good for helping to support various service lines within a hospital, and is also a superb resuscitation tool. So oftentimes, because it is a high-profile program, it, at least intellectually, you can get buy-in from the institution, and then just working through the steps of what it takes in order to have a functional program. And that's what this talk is about. Like I said, I've helped to start multiple programs around the United States and some other parts of the world. And one of the things that I've developed is this is a 21-page program evaluation form they're all practical questions, probably things that you would think of, trying to understand what resources and what commitment a given institution has for creating an ECMO program. Meeting for a couple days with the various stakeholders, really understanding what the positive and negative issues are within the institution, and trying to form a cogent understanding and uh, evaluation back to the program so that they can truly understand where the big issues are and where they need to focus. So one of the most important things is, who are you going to take care of? So there are three distinct age groups that are relevant. Is this going to be a neonatal program, a pediatric program, or an adult program? It could be any one of those or potentially all three. And then what are you going to go after? Are you going to be selective and only focus on respiratory failure? That has been kind of common with H1N1 and COVID. Or are you going to expand and also try to take on cardiac ECMO or even ECPR, ECMOs, derived cardiopulmonary resuscitation? So they all have very different implications regarding resource and expertise in order to have successful programs. So as part of that, you have to identify the needs. And again, what are you going to try to do? Are you going to help support high-risk service lines, such as the cath lab or other things? And what is it going to take? How many patients are you likely to be able to serve within a given year? A lot of groups or some papers have suggested that you need somewhere between 12 and 20 patients per year in order to maintain basic competence of a team. There are things one can do in order to enhance competence, of course, and simulation has been incredibly helpful with regard to this. And then establish and maintaining expertise. It's surprisingly resource intense. There's always going to be that initial training that's required, but then ongoing education. It has a lot of different impacts, financial impact, the ability of the multidisciplinary team to need to come in and have time for this education, and it has to adjust as well as the patient requirements might change. If your volumes are going up, your team may have greater exposure on a regular basis, and there will be new equipment coming in. We've seen a lot of that in recent years due to supply chain issues. So all of this needs to be put in your calculus as part of optimal program maintenance. And then secondary impacts. So there's a lot of good things that come from having an ECMO program that's viable, such as supporting procedures within the hospital. You can have ECMO on standby for transplant patients, for the cath lab, for out-of-hospital arrests or other things. And do you want to be a referral center, or do you see yourself as a spoken hub where you're going to stabilize a patient and then send that patient to a tertiary or quaternary center for ongoing management? So those are very different types of programs where a full capability program is going to try to do everything versus a program that may initiate a respiratory failure patient and then transfer to a tertiary center. Having governance of the program, very, very important. It's there isn't a perfect structure for this. And again, it's important to gather the right providers, stakeholders, in order to make sure that representation is covered for the various critical areas. Again, this sort of thing, building the team, if you will, is one of the chapters in Leading Change, and it's a very well written section. So it doesn't mean either that as you put out your first governance structure that it doesn't have to modify. You may need to bring in other individuals that are relevant to decision making and ensure that your communication is really good for all those that are needed. So governance has to have a core, and that core is going to be the executive team. Usually, most programs will decide to have a medical director, a surgical director, and then a program coordinator, and that's going to be your core. The medical director focusing on overall supervision and medical-based decision making, the surgical director aiding with all those things surgical, and then the program director being the glue that keeps the program together and coordinating education and helping with the implementation of direction from the other two directors. Then there's the all of the other stakeholders involved, perfusionists, surgeons, and the consulting physicians. ECMO, because of its care for very complex patients, involves so many different groups. And you'll find as you really focus and improve your program, how much better your relationships will become within the hospital, because you'll be interacting and working out problems that occur between pharmacy and radiology and transfusion lab and laboratory, and all of those areas that are essential for a well-functioning team. You'll need an operations team and also a group of bedside providers, the physicians and the ECMO specialists, to help implement the care that is needed for your ECMO patients. Financial structure is also critical, and in part because the cost of starting a program and maintaining a program can be very high. At least in the United States, we're able to maintain a good balance between cost and reimbursement, so that programs, generally speaking, run in the black to some percent. The large startup costs, sometimes programs can get offset with the help of foundations or donations through their charity arm within the hospital. And that helps to get the multi-$1,000 equipment required and possibly covering for training that is essential for starting up programs. It's also critical that you understand the reimbursement process. In the United States, it can differ by region, and it's essential that you bill appropriately, and part of that is understanding what is billable, and also supporting billing with appropriate documentation. One also has to have an ironclad supply and restocking methodology, so that your equipment stays up to date, doesn't expire, and your disposables, and that you know what you have on hand so that you can support your patient population. So there are a number of different financial stakeholders that are that you'll need to understand as part of the process. There are the insurance payers and what they are willing to reimburse. They may require education to understand what ECMO is exactly, and contracts that are developed with them need to include the use of ECMO so that they appropriately support this incredibly helpful method of patient care. Um, Health systems that sell insurance um, have to understand the high cost to the health system, but also that those costs can be reimbursed through the methods that are used for that. Health systems that do not sell insurance um, can have a massive cost burden and need to understand how ECMO programs are essential for internal programs such as cardiac programs, transplant programs, or maybe as part of a marketing strategy to show the quality of their hospital system compared to others. As I mentioned before, medical foundations can often help with supporting funding for the durable equipment through fundraisers or other means of donation. And lastly, it's important that the medical providers use appropriate billing for accounting for the work that has been done so that it's appropriately reimbursed. There's a number of different costs associated with running a program, including the human cost. Time necessary needs to be set aside for the medical director and those helping to that are part of the core supervision. The surgical director and the ECMO coordinator all need to have time supported so that they can help take care of the complexity of what is needed to appropriately run the program. Capital equipment expenses are high for the durable equipment. And again, external funding, foundational funding can help offset some of that. Disposables, even if you're only keeping a disposable primed and ready, throwing those away every month can lead to a high amount of extra costs. So trying to make sure that those are used for training and other things and nothing goes to waste. So quality improvement is critical. I can't overemphasize the importance of putting time into quality improvement as part of the program and making sure that one, with intellectual honesty, looks through every single case with a fine-tooth comb and understands what went right, what went wrong. It's also critical that at least quarterly, from a program standpoint, you review costs and sitting down with the accountant that is able to put together costs for your program and going down each service line, line item by line item, to understand what are the pharmacy costs, what are the personnel costs, etc., so that you can get a baseline and understand where you may be able to improve that ratio of cost versus revenue. So supply chain optimization has become a huge problem. Multiple manufacturers have run into problem with the FDA or other professional organizations related to their product, and these products may have either permanently or temporarily been taken out of supply. So making sure that you have enough of what you need and that you are training not just on a single component, but at least two different um, pumps, oxygenators, so that you're ready for supply chain disruption to maintain your program. So physical requirements are critical. It takes space in order to store your disposables. You have to be able to access them quickly. You need a mobile storage cart if you're going to respond to the bedside for applying ECMO to patients. You don't want a storage cart with tiny wheels. If that cart has to move from point A to point B and that distance is long, there's all these nuanced issues that are critical for the various requirements of putting together an elite program. Um, you want to make sure that you have backup consoles, because singular consoles can go down and you may have to switch it out. Ultrasonic flow probes can get broken and you may not want to go without the ability to monitor your patients. So redundancy is critical. High quality education and training with realistic sims occurring regularly, so that this initial training and maintenance training is an expectation. And doing regular drills at least every 6 months, probably more frequently, and then an annual exam using sims. Having minimals for pump time and other things. Staffing models are very important, and there's variations in cost. A perfusionist-based model is more expensive than an RN, or a hybrid model of using respiratory therapists and RN for the bedside providers. And then lastly, the information management. Are you going to belong to the ELSO registry? And it's a great thing to do, but realize that there's a lot of hidden costs. There's costs to belong to ELSO, and then there's the time required for data abstraction and filling out the forms. I highly recommend being part of it. Just realize that it's the tip of the iceberg, and there's so many other things that also so many other issues that one can attend to: credentialing, protocol development, quality improvement projects, resource availability. So the privileging process can be broken up into medical management, cannulation, and advanced cannulation. And lastly, how do you manage these limited resources of availability? We've had issues during COVID of having all of our pumps being used and not being able to take on more patients. So this is a critical thing that you need to consider as part of the development of your program. What can you take on? When do you say, okay, we can't do any more right now? So I would like to end with saying that program development requires time and money. You have to be strategic. It's okay to start small and then grow over time. Critical that you develop competencies and privileging so that you maintain a high quality program, and that realize that ECMO exists within a hospital framework is very beneficial to the hospital and its patients. You just have to understand the constraints that it places on resources. If you want to build a ship, don't gather people to collect wood and assign tasks. Teach them to long for the endless immensity of the sea. Thank you very much.